really thrilled to welcome you all here today to what is an interdisciplinary, school-wide intellectual convening on the issues of our collective future. I'm Linda Freed, and I have the honor of serving as the dean of this amazing School of Public Health in a great university. And today to welcoming you to really the conversations of the year, which have to underpin this school's commitment to a healthy and just world. I'll stop by saying there are a few seats in the front. For those of you in the back, please come down and take them. The commitment of our school to creating the knowledge and the solutions to enable health for all in a just world is underpinned by what we have learned, that you can't have health without strong public health on a foundation of human rights and a social compact of what we all can deliver together to accomplish those. The Dean's Grand Rounds on the future of public health, which occur approximately monthly throughout the year, is our school's one intellectual convening across all public health disciplines to really appreciate together the issues that enable and the issues that block the accomplishment of our mission. To be able to recognize that these issues are inherently interdisciplinary and require all disciplines to both understand them and to do their part to enact solutions. The theme of this year's Grand Rounds is dedicated to sequentially and serially tackling the big questions that must be solved for our future, for public health to have the most effective and impactful leadership. And the question we are asking this year is, what would it take? This brings us to today's event, which is the first of these Grand Rounds, that highlights the important intersection and skill foundation of public health in communicating. And ask the question, what would it take in the era we are in to effectively, impactfully communicate and motivate so people understand that public health requires all of us together to enable the conditions in which everyone has the full opportunity to be healthy, building on the science that says that health is possible if we enact it together. Now, we recognize that it is a fraught time on communicating around public health. It's a fraught time for public health scientists, practitioners, and policy leaders. It's a challenging time for journalism. It's an essential time that we come together to understand both the threats to communication, the solutions, the skills, and how we have to enact them together in order to create health for everyone. Dean Cobb, who I'll introduce in a moment, and I were just saying that there are kind of three eras in our lives right now: pre-pandemic, pandemic, and to the degree that we're post-pandemic, coming out of the emergencies, this new era. But the pandemic itself has forced public health to operate, to communicate under a rapidly changing perfect storm of altered conditions around communication, a reliance on virtual technology, challenges in the rapid transmission of information in a setting in which untruths, even lies, carry faster and more compellingly than truth, and in an era of both intentional misinformation, disinformation, and even malinformation, compounded by the politicization of health. This perfect storm of threats demand new approaches, new challenges, even new dimensions to our skills and our unity in how we communicate. This year's theme of What Will It Take and this opening Grand Rounds builds upon the framework of our thinking in last year's Grand Rounds, which is to understand public health as a foundational public good for society. This year, our intent is to take that understanding to the next level, to figure out in this perfect storm of challenges to communicating about public health, for public health, and to accomplish the public's health, how we actually now lead in a new era of communication. Essential in saying, what will it take? I'll give you one quick example. The evidence would suggest that at least half of all chronic diseases are preventable, averaging across different diseases. And therefore, we need to lay the basis for people to not get sick in the first place. But just empowering a public health system or different players to use investments to carry that out is not sufficient if the public and policymakers don't understand the potential if we align to create it. And how we communicate to persuade is part of that. How we communicate for shared understanding and belief and valuation is part of that. So on that note, it's my privilege to turn this conversation over to three pros. And I'm going to start by introducing our eminent moderator for this session, Dean Jelani Cobb. I told Jelani that, as did others, that he has a large group of groupies in this audience. But I'd like to explain a little bit about what makes people say that. Dean Cobb joined Columbia's journalism school faculty in 2016, and to many of our joy, became dean himself in 2022. He is a longtime, eminent, highly regarded staff writer at The New Yorker since 2015. He received a Peabody Award for his 2020 PBS Frontline film, Whose Vote Counts, and was a finalist for the Pulitzer Prize in Commentary in 2018. He's the author of The Substance of Hope, Barack Obama and the Paradox of Progress, and co-producer on a number of documentaries, including Obama, A More Perfect Union, and Policing the Police. He currently serves on the board of directors of the American Journalism Project and was elected to the American Academy of Arts and Sciences in 2023. Dean Cobb, welcome to the Mailman School of Public Health. We are thrilled to make you an honorary member of the school. I'm particularly thrilled, and to turn over to you the introduction of our panelists. Thank you.
Good morning, everyone, and thank you for that introduction, Dean Freed. You know, there's a kind of, there's I'll let you in on a secret. We have a weekly meeting among all the deans, and I really admire all my fellow deans. But that said, you know, there's some people who I look forward to hearing in these meetings more than others, and I'm always eager to hear from Dean Freed because she has a way of, you know, getting right to succinctly to the point of the matter. That many of us have been circling around for the last half hour, and she'll kind of say something like, yes, thank you. And I'm also happy to be able to come here up from the Morningside campus. I'm embarrassed to say this is my first time in this building, and you know, but I'm happy to be able to make the acquaintance of another constituency, another community at Columbia. And so I'm just going to give a brief kind of overview of my vantage point on this question. And then I'm going to introduce our panelists, and they will give brief remarks, and then we'll have a conversation that I will moderate. So I have twin sons, and in about 12 days, they're going to turn 4. I know. And so whenever people say that, they're always like, sometimes I think people have done the calculation. Yeah, they were born right before the pandemic. And so right before lockdown, actually. And, so when lockdown occurred, we had a 2-year-old daughter and like 4.5-month-old twins. And it was kind of like amazing that no one did, like, those nature shows where like the animal will chew off a limb in order to escape. We kind of felt being in the house sometimes. But the twins are good at marking time. Since the time period around their birth marks, just how far we are past that really shocking, terrifying moment when everything around us shut down. And the onset of the pandemic scrambled some things and made some other things much more clear. And what I mean by that is that it took our kind of established order of our lives and just turned it upside down. It's like put it all in a blender. The things that we thought, the routines, everything that we did, that was all turned around. It also had a way of clarifying things that had been obscured, not really ever truly obscured, but obscured to such an extent that we could not see it if we didn't want to. And what I mean by that is that the arrival of the virus stripped away the facade of equality in our society. It was very clear, based upon who you were, where you lived, what your socioeconomic status was. And all of these things factored into your ability to get out of the path of this virus, or the likelihood that you would be placed directly within it. We may have hypothetically had some ideas about which jobs are essential to the day-to-day functioning of our society. The pandemic stripped away any illusions we had about that. Seldom had we thought about the heroism of our neighborhood grocer, of the cashier, of the food delivery person, of the people who drive our buses and who conduct our subways. And all these people, day after day, arose and went out, walked out of their homes into the path of this virus. Interestingly enough, this virus was called, initially be referred to as the novel coronavirus because it was new. And when we looked at the data around who was primarily being affected, or who was disproportionately being affected, we saw it popping up in ways that replicated other kinds of social indicators that we're familiar with. And so my sardonic question in the midst of this was that if this virus is so new that they refer to it as the novel coronavirus, how did it get the address of the hood? How did it know how to find the most vulnerable people? How did it navigate to the zip codes where we see other social shortcomings and inequalities manifest themselves? For me, as a journalist, this was a topic of inquiry, and I knew it would be the crucial story. It would be the thing that we had to explain to the public. But we were navigating a problem of our own, which was the declining faith that people have in media organizations, in media institutions. We began by explaining and doing the kind of work that we do as journalists, digging into finding the experts, finding what was going on, finding what the implications and ramifications were, and doing our best to inform the public. But we did so in a context in which any individual with a social media account could begin taking pot shots at the work that we'd done. and we faced a real credibility crisis. And the credibility crisis that we confronted was similar to the credibility crisis that you all confronted. And that is when we find ourselves in a position where we have worked extremely diligently, we've done our best and followed our professional protocols and ethics and so on, and we present information to the public that seems to place us on par with a social media influencer who may or may not be in full possession of their wits. And so this is a kind of a paradox, obviously, and it's a kind of frustrating question. But I've thought about a few things, one of which was that we quickly became aware that the virus would have outsized effects and the most deleterious effects on people who had a particular array of comorbidities. And that the virus was in some ways, and its ability to do damage was in some ways a barometer of the underlying health of the individual who had been infected. So we learned this fairly quickly. What we were slower to recognize was that the pandemic was a barometer for the societal comorbidities that had existed prior to the existence of the virus, before it had ever arrived here. It was a way of understanding just how poor off or how well off individuals were, how strong our institutions were, how good a job we had been, how healthy we were fundamentally as a society before the virus arrived. Now, there are a number of things I could go into. I have 5 minutes and then I have to introduce, and I think I'm at about 5 minutes now, but I'll just say this very quickly. One of the things I think is most notable to me is the way that this connects to bigger questions about our democracy. If we take the perspective of Thomas Jefferson, individual who I had many issues with, but he also said some things that were useful. Thomas Jefferson pointed out, he had a philosophy about the real strength of democracy being in localism, that distrusted kind of large aggregate conglomerate metropolitan environments, but he thought that the local entities and local outlets would be the strongest bastions of democracy. Well, it's in those places that we see the biggest crises. For us in media and newspapers, it is no secret that the news industry has been cratering in the wake of the way the internet has disrupted the established business models. The overwhelming preponderance of that effect is being felt in local news. Local news has a greater degree of credibility than national news for reasons that are deeply rooted in American history, the history of the society. We have always been more trusting of local institutions than we have been of national institutions. At the very point at which we needed to communicate directly to people, the institutions that they were most likely to trust had been removed from their lives in terms of media. A similar thing is true in medicine. Early in the Biden administration, President Biden advised people, as there was a kind of vaccine resistance, he advised people to take to follow the opinion of their personal physician. He said, just take your doctor's advice, presuming that their doctor would tell them that the vaccine was safe and encourage people to follow the protocols that the Biden administration was hoping that they would. I looked at that and said, that's the same problem that we have, because 100 million people in the United States do not have a primary care physician. And so our crisis on both these scores and many other scores is a profoundly local one. And the last thing that I'll say before introducing our panelists is this. If we think about the pandemic as a barometer of the underlying health of our society, it means that we have to examine the places in which we have failed as institutions. We have to take a hard look at the failure of journalism, to take a hard look at the failures of health and public health, our medical industries, to take a hard look at all these places and say, how is it that people were in such a place that such seeds of doubt could be sown in the first place. Until we are willing and capable of examining our own shortcomings, we have no hope of possibly looking at the bigger context in which this has emerged. And to find, even those of us who are really exacting, who care a great deal about this, institutionally, we have to think about where we have fallen short. And it is an impossible task, almost. But I'm reminded of that joke by Chris Rock, where he said, you know, airline pilots don't get to say that they land safely most of the time. And so with that, I will stop and I will introduce our fellow panelists. Thank you. Salim Abdul Karim is a clinical infectious disease epidemiologist who's widely recognized for his research contributions in HIV prevention and treatment. He is Caprisa Professor of Global Health in the Department of Epidemiology at the Mailman School of Public Health at Columbia University. He is also Director of the Center for the AIDS Program of Research in South Africa, Pro-Vice Chancellor of Research at the University of KwaZulu-Natal in Durban, South Africa, and Adjunct Professor of Medicine at Weill Medical College of Cornell University, which is to say you were very busy. His contributions to microbicides for HIV prevention spans 2 decades and culminated in the Caprisa 004 tenofovir gel trial, in which provided proof of concept that antiretroviral drugs can prevent sexually transmitted HIV infection and herpes simplex virus type 2 in women. I'm happy that I got through that whole sentence. He is the chair of the UN AIDS Scientific Expert Panel, chair of the WHO's HIV and Hepatitis Scientific and Technical Advisory Group, and I'm going to jump through some of this. He serves on the boards of the New England Journal of Medicine and the Lancet Global Health, Lancet HIV, and the Journal of AIDS. And crucially, during COVID, Dr. Karim was called the Fauci of South Africa, giving hundreds of interviews to explain the science behind the epidemic and the need for public health interventions to limit transmission. He recently released the book, Standing Up for Science, A Voice of Reason. Perry Peltz is a documentary filmmaker and journalist, co-director and producer of Alternate Endings, 6 New Ways to Die in America. She's also a public health advocate, and she's co-director and producer of the HBO documentary series Axios, and a radio show host on Sirius XM. Most recently, she directed Alternate Endings, 6 New Ways to Die in America. Previously, she directed Warning, This Drug May Kill You, and Risky Drinking. She directed and produced Remembering the Artist, Robert De Niro Sr., and The Education of Dee Dee Ricks. There's a whole array of really impressive work that she's done here. She won an Emmy in 2021 for her interview with President Trump. And previously, she served on the board of advisors for the Columbia Mailman School of Health. And so I will turn it over to Professor Abdul, and we will take our seats in order. Would you like to give your opening comment?
Sure. Thank you very much, Jelani. It's a great pleasure and honor to be with all of you here today. As I was reflecting on what are the communication challenges that we've been facing in the pandemic, it struck me that there's a broader problem, a broader issue we need to address. What is the lessons that we can take from this pandemic as we prepare for the next pandemic? And those who are not expecting a next pandemic, I got bad news for you. There's likely to be one. And of all of the issues that we grappled with, two stand out for me particularly. The first is the challenge that we grappled with in trying to make the countermeasures like vaccines, like diagnostics, like therapies, trying to make them equitably available across the world. And for me, the number one challenge was the challenge we had in addressing vaccine inequity. The second was to deal with the way and the importance of science in dealing with the pandemic and how science is under attack. It is being challenged in a very roundabout way, but quite a difficult way to deal with, and what WHO has referred to as the infodemic. So I'll touch on those two issues because they were so central in two of the biggest challenges we dealt with in COVID. So just briefly, I don't need to go through the details of vaccine inequity, but to give you some idea, the US had already vaccinated 50% of its population when South Africa got its first doses of vaccine. And the reason was very simple. There were 5 countries that made their own vaccines: the US, the UK, Germany, Russia, and China. So those countries were the first to vaccinate their populations. China started first, even before they had regulatory approval of vaccinating the military. Russia followed shortly thereafter. And then the first official vaccinated person on the 8th of December, 2020 was in the UK. It took an additional 5.5 months before South Africa got its first dose. And this was despite the fact that scientists like myself, together with our government, started negotiating with companies like Pfizer to acquire their vaccines as quickly as possible. But what emerged is that we took our most powerful weapon that we had against this pandemic, and we said to drug company executives, you dish it out as you wish. If ever there was a recipe for disaster, that's what it is, because they protected their markets. So if you look at, for example, in Canada, Canada had hedged its bets. And so they purchased almost every vaccine that they could. And so when you look at the situation in April of 2021, they had purchased 9 doses of vaccine for every one of their populations. And so they were already receiving different kinds of vaccines and were hoarding them at a time when most of Africa had not yet seen a dose. And the effort that was put in to address global inequity in vaccines, which was through a mechanism under the ACT accelerator called COVAX. COVAX had the noble challenge of making vaccines equitably available. In short, it failed us. It failed us not principally of its own doings, but it failed us because it was not a preferred market for the drug companies. The drug companies were giving it no leeway. They had no preferential buying, and so they were at the back of the queue. And so if you waited for COVAX vaccines, you were getting vaccines more than 6 months after the US and the UK. That situation is unconscionable. And if we had another pandemic this year, we have no solution to that problem. That same problem would occur again. And every effort that's being made to solve that problem hinges right now on one critical mechanism called the Pandemic Treaty. So at the UN General Assembly, all the countries agreed that the WHO should lead a process that will lead to a pandemic treaty. And that pandemic treaty, in its zero draft, included specific language and clauses that would make vaccines equitably available. Very simply put, what it suggested is that every country that made vaccines, that they would use half of all the vaccines they made for their local population, and the other half would be given to COVAX if COVAX wanted to buy it. So COVAX was a preferred buyer for the other half. That clause didn't make it in the first week. It was demolished, removed, so it doesn't exist. We have no clause right now in the pandemic treaty to deal with equitable distribution of vaccines. So who dies, who lives, will be determined by drug company executives in the next pandemic if the current situation continues. The second issue I want to touch on very briefly, because that's what we're going to focus on largely in today's discussion, is that time and again, studies have shown that medical professionals are very highly regarded as sources of accurate information in health. What we found in the pandemic, when it came to distributing misinformation about treatments, and here I'll specifically refer to hydroxychloroquine and ivermectin, the main promoters of misinformation on both those agents were doctors. So the very source that is our primary bulwark against misinformation actually became the sources of information. I decided to take on one of those doctors in South Africa. Didn't take 2 days before I was served with lawyers' papers. They will do anything to protect themselves because they believe in their cause, even though it's a misinformed one. And that has become one of the difficult issues because they fundamentally challenge the basis of science. And when you look at the anti-vax movement and the number of doctors who are part and parcel of that, they play a big role. I mean, we all know in the US, they described this, the 12 individuals, what they call them, the dirty dozen or the misinformation dozen, who are the dominant force in promoting misinformation. They are also, many of them are also the main source of misinformation in South Africa, just to show you how connected our world is and how in social media, people like Robert Kennedy and the Children's Defense Fund is the main source of misinformation on vaccines and overestimating, overplaying vaccine side effects, even in South Africa. And I think that that's the challenge we're going to face as public health professionals, is how to take on that misinformation in a way that doesn't look like we are always on the defensive, but in a way in which we can compellingly explain how we need to prepare and think better about the next pandemic. Thank you.
The reason that I came back to school is we were talking, you look at local news, for instance, there's a lot of public health that's sitting in front of you. Shootings, but you're not talking about the root causes. You're talking about the end result. Like I said, car crashes, you're not talking about the seatbelts. You're talking about what happened. I could go on and on and on. You don't talk about alcoholism. You just talk about the beating that happened as a result. You're not talking about what happened in why people are living in prison or why people are in prison. You're just talking about the outcomes. So I struggled with this and tried really hard to move towards a place where we could talk about the public health issues. And finally, I thought I had arrived at ABC News. I was a correspondent for the show 2020. Some of you may be aware of it. And I was supposed to be covering public health issues. And my very first assignment, and I am not joking, was a piece on the Super Uplift bra. And that is true. And that was followed, and I am also not joking, on adjustable breast implants. So that was the idea about what was public health. So it is something that I have struggled with for a really long time. And Dean Freed, when I started here, you and I struggled with, how do we communicate what public health even is? We made a video about what public health is, because when we question people about what public health is, everybody said, oh, they're the nurses who come and give you vaccinations. And of course, that's not the answer. Public health matters profoundly. I don't have to tell you all of that. You're all here because you know how much it matters. Communicating it really, really, really matters. And we do a lousy job at it. The problem is that everybody was able to ignore it for a really long time. And then COVID happened. And that, for the first time, was a crash course for this country, for the world, about what public health is and why public health matters. For me, I was directing and producing a series for HBO with the news organization Axios. It was a documentary news series, and we interviewed everybody relating to COVID. We were with the head of COVAX. We went to the company in India that was making the vaccines. We did the head of WHO, the NIH, you name it. We were there. The problem is that communicating issues of public health right now are really difficult, because the primary care providers can go directly to people by going on social media. And the problem is that there's a lot of misinformation that gets put out there, and there's a very limited role for journalists to come and question people, to challenge people, to ask the questions that really matter. A lot of people in public health in these very important positions that matter profoundly to the public don't want to talk to journalists. They don't want to answer those difficult questions. And what happens is the negotiation to get these interviews is unreal. And if they don't like what you're going to ask, then they just say no. So when you think about what it is that we can do to do a better job of communicating public health, ultimately, what I learned is, and this is a simplistic answer, but it's at least a start, is that we have to be able to take communication of public health issues as a part of the plan from the very beginning. You can't just do the public health work and then not figure out how to communicate that, how to partner with the communicators, whether it's storytellers or documentary filmmakers or journalists. It really matters. And to all of you who are going into this world of public health, all I want to say is that working hand in hand with journalists, with storytellers, really, really matters. It matters that we tell these stories well and that people understand what the public health issue is at hand. Because we all know that we can't have healthy societies without having a really solid communication of what public health issues are and why they matter. So that's my opening thoughts.
Thank you. So I had a conversation with Dean Freed, some weeks back, and we were talking about the astounding differences in life expectancy and all sorts of kind of health indicators that public health is responsible for over the course of the 20th century. And the public being virtually unaware of that. I wonder if you could talk about, one, how that came to be the case, and two, how that might factor into the dynamics that both of you have talked about in your opening statements.
Maybe I'll go first.
Yes, go first.
When we think about healthcare and we think about health, we often don't think about it as health. We rather think about the disease. We think about the state of not being healthy. because that's the state that's one that's more catching, because most people are without a disease. Let me give you an example of the point I'm trying to make. If there's a conjoined twins where there's a surgery to separate them, it makes front page headlines. It's a big deal. And it's because of the nature of the ill health and the sheer bravado of the doctors who are doing the surgery that's portrayed and the way it's communicated, that's what captures the imagination. But in truth, public health is ensuring that there are far fewer conjoined twins than what we are seeing. The actual work of trying to prevent this problem and trying to mitigate its effects is actually done by public health, but it's done out of the public eye. And I should know this because I've spent my life working on HIV prevention. And I can tell you, it's very hard to talk about not having a disease or how you should not get this disease. But it's a lot easier to deal with the actual ill health state. And that's one of the big challenges we face in our communication. And what we haven't done well enough, I think, Johnny, in conveying this, is that I think we haven't talked enough about the underlying issues in ill health. And I think that's what you were getting to, Perry, in that we see things in isolation, not in terms of their linkages. We don't see the fact that you get vaccinated, the fact that your environment is clean, your water is safe, all of those issues, we don't link them together. We don't see them in part and parcel of health. Instead, we compartmentalize them. And because we don't see the linkages, we tend to underplay the value that they bring. And so public health, which is such a broad brief, gets shortchanged in this equation because they don't have that bravado, they don't have that Superman coming out there.
That's interesting. It's like the dog that didn't bark, the dog that didn't bark, right? It's like showing that there are people who don't have a disease, and we're probably guilty of that same thing in media as well.
Yeah, I was just
Yeah.
going to say, prevention doesn't sell, is what I was told. And that is to some extent right. Like you've got, ultimately, you need people to turn on the television, you need people to read the newspapers, right? So there is some validity in this notion that the story's got to sell. And I think that one of the ways that I came to think about it, I switched from news into documentary filmmaking around an issue that I care deeply about, both academically and experientially, which is the disparities in healthcare, not around the world, but right here in our country. I was so tired of everybody saying, talking about what was happening in developing nations, when we have disparities that are right here in this city that are profound. And I remember when I was at NBC, trying to get a story on the air about two women in this city. One woman had health insurance, one woman didn't. One woman was white, one woman was black. They had the exact same breast cancer. One woman died, one woman didn't. And the one woman who died, as you probably well can imagine, was because she couldn't access our healthcare system. Not because the most extraordinary healthcare doesn't exist here in this city, but it's because she couldn't get into the system. And by the time she did get into the system, she had stage 4 breast cancer that had metastasized. I couldn't get that story on the air. Eventually, I was actually able to sell it to HBO. And it was the first documentary that I made, and it was called The Education of Dee Dee Ricks. And the story was about these two women. And what I came to understand, and Johnny, I'm really curious from where you said how you think about this, is that the way that I was actually able to get the story on the air in a profound way, because HBO as a documentary media is incredible, is by finding the humanity and finding the people who could tell that story so that it became about them and not about the issue of access to healthcare, which of course is ultimately what the documentary was about, but by telling their stories and then sandwiching in and squeezing in the medicine of access to healthcare. And what I have found is that so often, whether it's about so many topics, whether it was the opioids film or the alcohol film or the death film or any of these things, it's by finding people whose stories are so compelling that you ultimately squeeze in the public health message to communicate it.
No, I think that's a really good point. We have those conversations about narrative all the time, because there's so many different ways to do journalism now, and people who do data, which is really important. Data can elucidate things in ways that we couldn't even dream of doing before. But there's still a kind of fundamental, I don't know, like what it is about narrative that relates to something that's just hardwired in us as human beings. And so we always kind of come back to this, like, how do you use narrative in ways that are compelling, that also can help you tell these other kinds of stories. I do have another question, though, which is, we've talked a lot about what went wrong. I wonder, from your own individual vantage points, if you saw really good examples of things that should be replicated in public health and communications around public health, things that you were looking and going, oh, like, bingo, we should be doing more of that. We can start with Perry and then go to Professor Killeen.
So what are things that were really good in terms of communications during the pandemic?
Right. Or if you didn't see anything like that, that's something, that's an answer in its own right.
Well, I was about to say, I sort of wanted to have a moment to think about it. No, and like I said, Tony, we were on the really on the front lines. When the pandemic started, HBO basically had to shut down all of its productions, except for us, because we were classified as news. And so we were then on the air twice a month, and they doubled it so that we were on the air weekly, and trying to navigate the world during the shutdown and making a television show, and was really complex. And it felt like, getting back to what I was originally saying, that we were fighting every step of the way to get these interviews, because there was such a void, getting back to the infodemic, which, by the way, was a shadow pandemic during COVID, and people died. A lot of people died because we couldn't get the information out. And from where we were poised, that was incredibly frustrating, because we knew how to get the information out, but we couldn't get it. And that was something that was profoundly frustrating as communicators, and as somebody who, cares about public health, understands public health, and speaks that language, couldn't get there. So sorry. Nothing.
So I'll look at one of the successful communications in COVID-19 and tell you a little bit about how we dealt with Omicron. Because it's actually a story about the good, the bad, and the really ugly. As far as the good is concerned, it was the 21st of November of 2022. And we had just seen the sequences that had emerged, and we realized that we were actually dealing with a virus that looked quite different from any of the previous variants that we had seen, Beta variant, Delta variant. And we didn't know what to make of this, except we knew it was drastically different. And when we had sequenced it and we looked at it and we saw it had over 50 different mutations, we knew we had to do something about it. We couldn't just sit on it. And so we shared it the next morning with the WHO. And the following morning, it was presented to the president of South Africa, and he informed us that we should go public with it the same day. So this is now a mere 2 to 3 days after we first discovered Omicron that we were going to go public and share this with the whole world and announce for everybody to hear that this is something they don't want to hear, but that we felt we had to share it. And when we went online, we presented this and we shared with the world what we thought was in this new variant. The repercussions were almost immediate. Right? That very evening, the UK imposed a travel ban on 8 countries in Africa, 7 of which had no reports of Omicron. And we explained to them that actually the first ever report of Omicron, which they hadn't identified, but it had been loaded onto the GISAID sequence database, was from Botswana. The second was from Hong Kong. If you were going to impose a travel ban, why not Hong Kong? But the racial issues that were involved in the travel bans, the US followed the next day with a travel ban, Canada as well. And so we had to deal with the consequences of being open, being transparent. But I'll tell you what happened next was that the editor of The Lancet sent me an email. This is about 2 or 3 days after we had made the announcement. And he says, Slim, you are everywhere here. You're on Sky News, you're on BBC, everywhere. You got to write something for the journal. The scientific community needs to know about this virus. And so Qureshi and I made that decision. We were going to write something. So it took us about 6 hours that day from the time we got his email to write the paper. We had our statisticians producing the graphs because we need to answer 2 questions everybody had on their minds. The first is, how infectious is this? What is it going to do? The second is it serious? Is it more clinically severe? That's the 2 questions. And that's what we answered in that paper. We got the paper written by about 4 o'clock that day, sent it into the journal. Within an hour, they sent us the reviewers' comments, and we fixed it up, submitted it back. By 6:30 that evening, it was live on The Lancet. Because of the importance of sharing information, because without that scientific data, rumors fly. And they go far faster than any factual information that we can share. And so to me, that illustrates, firstly, the importance of good science to identify the variant, good communication to be timeous, to be accurate. It showed us how bad the response can be in the punishment that was meted out to South Africa. Because, you know, about 2 weeks later, we ran out of reagents. We couldn't do any more sequencing because there were no flights coming into South Africa. And of course, the ugly side of all of this was that we were seeing how these travel bans were really fundamentally racist in the way in which they were being implemented. And as it's now very widely known in the Royal Society report that we've put together, actually Omicron had already spread in Holland, in the UK, in France, and they just hadn't picked it up because they didn't have in place the kinds of systems of surveillance that we had already in South Africa. And I wanted to just illustrate this to make the point you were making, Jelani, about the power of communication, but how you've got to deal with the consequences of it as well.
Can I ask a question of you?
Sure.
Same question that you asked, but did you see anything that you thought should be replicable in terms of way we were communicating during COVID?
So I saw, this is a very small thing, but I took note of those commercials that Dave Chokshi did because they were bad. But what I mean is by bad is they were not highly produced. And they were kind of like, yeah, you know, here's this guy, he's talking about public health and everything. And I actually thought, this is good. Like, it shouldn't be like super well produced. And it didn't look like highly polished. It looked like something that a person in an office that was overwhelmed with a whole array of things, but really needed to convey this to the public, would put together this thing and say, here, this is what we're doing. And he came across as somebody who seemed like an actual human being. And I don't know if that moved the needle in any particular way, but I remember seeing those commercials and going like, oh, okay, there might be someone who's on the fence who would actually be swayed by this. And so that was a small example. And then there were other people who I think did really kind of interesting work around that. The sociologist Zeynep Tufekci, who was doing a lot of stuff in the Times at that point, and I thought she did really interesting work as well. So we are going to open in a minute for questions from the floor, but we do have one question that was submitted. I want to get to at least one of the online questions. And this is a big question, but hopefully we can try to answer it as succinctly as possible so we can get to the audience Q&A. But the question is, what factors influence why public health communication can become so political? We have seen this across epidemics, HIV/AIDS, guns, COVID, chronic conditions, et cetera, and time. It's not just frustrating, but it often presents real barriers to scientific and public health progress, i.e. funding, political will, public sentiment, et cetera.
So one of the challenges we face in public health is that a lot of what we're trying to do is we're trying to get people to change their behavior. We're trying to get them to act differently. And so we fundamentally are challenging their freedom to act irresponsibly, if you like, or act in a way that they want to, even if it's harmful to others. And so we find ourselves in a situation where in public health, we are trying to promote behaviors that are beneficial to the collective. They are beneficial to the community. They are beneficial for a large population of people, but they involve individual sacrifice. And that's a challenge because not everyone is willing to make individual sacrifice for the collective benefit. And that's a very fundamental issue that goes directly to the heart of what defines much of our politics. It's the extent to which we believe that we should be able to do whatever we want, regardless of its consequences. If we want to own, the latest automatic gun, we should be allowed to do that, regardless of the fact that that's what's associated with the school killings. So that fundamental conflict leads public health to directly impact on the politics of the day. And it was probably most clearly seen in COVID-19 because we were telling people to wear a mask and they didn't believe that wearing a mask was something they wanted to do, even if it was good for them and good for the public and good for the community. They felt it fundamentally impinged on their right to do what they wished to do as an individual. And I think that that's the challenge we're going to face in almost all aspects of our public health, but it became most clear during COVID-19.
Sure.
I was just going to say that basically the same thing. It's the don't tell me what to do.
Which is kind of astounding when we think about the kind of scale of sacrifice that societies ask of their their citizens, which is under some circumstances, we ask the public to do things that might literally get them killed, or at least the portion of the public that belongs to the armed forces. Or we ask people to sacrifice some portion of their income for the better good. But putting on a mask, that's a bridge too far. Like now, sir, you have really stepped over a line. We have time for some questions from the floor, and so I don't know. Do we have a microphone, or are we just kind of projecting? Oh, yeah. Okay.
Hi, my name is Camilla, and I thank you all for the panel. This is so lovely. And so reflecting on the small brief incident regarding the Black woman and the white woman who were diagnosed with breast cancer, and then also you reflecting on the COVID-19 Omicron variant. I just was curious to know, like, how deeply ingrained do you believe the historical origins of racism in public health continue to influence society's approach to health communication?
Very.
Was that? Yeah, right.
There are many issues in medical care and public health that they fundamentally challenge who we are. And they force us to look at who we are. And the more your message does that, the more uncomfortable it is for people to deal with that message, because they are merely going along in their comfort zones. And I think back, I'll use a non-COVID example to illustrate this. The tobacco industry had romanticized and created cigarettes as something that was macho, it was something that was hip. You look at the movies and the way women would light up, and the way in which, the guy on the horse promoting cigarettes, and it conveyed certain images. And when we were trying to communicate that was a bad thing, we had to deal with a huge vested interest with a lot of money in the tobacco industry. And so it became a challenge of communicating which is the correct version and understanding of what tobacco is. And it took a long time, and it took a slow erosion of that image that the tobacco industry wanted the public to think of. And it had to shift. And some of it was top down, but a lot of it was bottom up. In many ways, just like how, condoms became hip, and we talk about condoms so openly because of the HIV pandemic, anti-smoking had to slowly become hip. It had to become something that was open, people began to move behind. So you needed a social movement. It needed people on the ground to raise it and deal with it. And I think for me, the issues around the uncomfortable pieces in the way in which we communicate in public health require that coalescence of bottom up and top down. And unfortunately in COVID, the top part of it was problematic in the US because President Trump was giving one message and the public health community is giving another message. And so you don't have a convergence, and so you can't create that oneness that pushes in the correct direction, that fights the misinformation.
There was that study, and forgive me, I'm taking a liberty. I was reading something in this study that talked about COVID infection and long COVID, one of the dynamics being erectile dysfunction. And I was like, why did they not lead with this? I was like being cynical, but I also was like, no, seriously. Like, you would have dudes lined up in masks like, hey, I gotta get my shot for real. No, seriously, I need to get the shot. No, but honestly, I felt like there were kind of points at which the thing that you're talking about, kind of marginalizing the idea, marginalizing racism around it. And even I think the use of humor. I was being funny about that, but also the use of humor is an incredibly powerful tool in communication. And I don't think we see very much of that either.
Can I just add something to your excellent question? And the answer is racism infects every single story in every single level. And we have to, as storytellers, think about it all the time. And for me, it became an issue around the opioid epidemic. In 2017, I was assigned to do a documentary for HBO, and it was a film that the mission was in 2017, the story, the narrative that the pharmaceutical industry was putting out is that it was bad kids abusing good drugs, that kids were going into their parents' and their grandparents' medicine chests and they were stealing these very good pain medications and taking them. And of course, that wasn't the story, right? The story is that people were becoming addicted, and 80+% of the time, it started with a prescription drug from possibly a very well-intended physician, but that's what was happening. And what was really interesting, getting back to the race issue, is that what was happening is that doctors weren't prescribing pain medications in the same way to Black people that they were prescribing to white people. So when it came time to tell this story, we started only seeing white people. Like, why is it that there are only white people? And of course, the bottom line was because they weren't getting prescribed. Black people were not getting prescribed in the same numbers. So there was sort of this odd reverse racism issue that was happening. And so we made a very conscious decision. We told 4 different stories of 4 different people, all of whom became addicted from the prescription from a physician. Some of them turned to heroin when the prescription ran out, but they were all white people. And we got a finger pointed at us by saying, well, where are the Black people in the film? And the answer was that we had made a very clear decision that was a part of the story, was the fact that it was white people because of this terrible reverse issue that was happening, where there was just this disparity in the way that people were being prescribed pain meds. And that was having this bizarre sort of downstream impact. So the answer is every single step of the way. And as storytellers, for those of you who are interested in that, we have to always be aware.
I think we can squeeze a few more questions in.
Yeah. Okay. Okay. Hi, Ami Soda. Thank you for this insightful panel. I'm faculty in environmental health sciences here at Mailman. I do a lot of science communication. And for the last 5 years, I now run a national fellowship program where we're trying to shift narratives in environmental and climate justice by training emerging scientists in storytelling and science communication. So a lot of the stuff you're talking about. And we kind of see one of the next frontiers in terms of training to be really around mis, dis, and malinformation, right? And so that's kind of what I want to ask you about, is both from the journalism and the public health scientist profession, kind of professional background, I really see this as a big gap in training, right? And what do you see as best practices for our emerging leaders, both in journalism and in science, to both, both kind of in terms of what they can do individually, but then, I think about climate, another hot button issue. There are real commercial interest, right, in kind of creating, manufacturing doubt, right, creating noise, in the public sphere. Thank you.
Thank you.
Can we just have one of you answer for the sake, so we can get as many questions in?
Yeah, I'll just very quickly respond, which is whenever one hears the word commercial interest, it gets back to this point about the fact that so many people want to communicate directly and bypass journalists. And it doesn't work because people need to hold these companies and hold these people accountable. And if they're just delivering these messages through social media, we are going to have an enormous problem. So my solution, or my part of the solution, is we need journalists and people in the public health space need to hold hands. Journalists need to understand more about the public health issues that they are communicating about. And the same thing with public health professionals need to be thinking about the rollout and the communication plans around what they're doing.
Yeah, we have some questions up in the front.
Who's first? Here.
Hi, thank you so much for this panel. This is very exciting. I direct the Health Communication Certificate here at the School of Public Health. And thanks for sharing that this is your first time in public health, because I haven't really been over to journalism.
Because
I have not been over to journalism.
you have an open invitation.
Thank you so much. But how can we just here at Columbia communicate more between the School of Journalism and the School of Public Health? This is a wonderful first start. But historically, it's been hard for just even here at Columbia for School of Journalism and School of Public Health to come together?
This is the conversation we had. That's literally the conversation we had. And we're going to be exploring ways to do exactly that. And so we both, I think, recognize the importance of this mutually, to both our institutions.
Thank you.
I just want to point out that during the pandemic, there were 2 public service videos that were released. They were very, very well received. We did not work with the School of Journalism, but this is an obvious segue. The other thing I wanted to point out, and sort of talking about things that we've done well here at the school, and this is for you, Perry, was the work around vaccine and Wakefield and all these other things. When you introduced Jane Rosenthal, and we were able to prevent the showing at the Tribeca Film Festival of something that was obviously a misrepresentation of the risk.
That was Robert Kennedy.
She was Bob De Niro
Right.
and then
well,
Robert F.
yeah,
Kennedy.
exactly. Yeah,
But it
exactly.
continues to current day. I think that's probably enough. You can pass it on to somebody else. But I'd be very interested, I think, there were 2 public service videos that we released, one of them by the entire cast of Contagion, and the other, the cast pushed back and said, we should have people from the community talking about why they're getting vaccinated rather than Hollywood people. And I think it did make a difference.
I think, let's see if we can squeeze 2 questions in. We can do like all right, let's 3 speed round questions. We'll do it like this. Ask your question. We won't answer it, but ask your question, and then we'll go to the next person. They will ask their question, and then we'll go to the third person, and then we'll deal with all 3 questions at once.
Okay. My name is Yanni. I studied journalism in undergrad and I'm a current public health student. Seems like no matter what field I'm working in, advocacy, politics, these classes, seems like we really like the answer is community care. But the big question is like in these fields of journalism and public health, how are we making those steps towards collectivism and community care? And if not already, then what would spark that to happen?
Hi, thank you for this. This has been great. Understanding that the conversations we have surrounding public health are inherently political due to the recommendations that we make and the freedoms that sometimes people may feel that we've kind of encroached on. And you kind of touched on how South Africa also experienced some vaccine hesitancy as well. I was just curious if having that international work that you have all kind of experienced, is it different in the United States, the way that we push back or politicize public health issues? And if so, do you have an idea of why that is? Really big question, I know.
So the first question is about obstacles to collective care. The second question is about the extent to which the pushback here in the U.S. is unique. And we're going to make sure we get to this question. So you ask your question, and then we'll get this person in the front will be the last question.
My name is Janie Crispin. I'm a psychologist who's been with a long interest in public health, not to give you a whole to-do. What I'm particularly interested in, which you touched on, is all these epidemiological issues that aren't that hard for young people to learn. If they can be taught the scientific method in science class, why aren't we making more efforts to educate the public so people would hear these things and that would resonate with something they've learned? And if we could get to kids, we could also get to their families. That's what we used to do. And that's what happened with AIDS, right? We had to find a way for parents to talk to their children about condoms without feeling they were talking about sex, that they could talk about. And that's one of my interests. So I'm just throwing that out.
Okay. And so I have a question about education and young people. And we can have, this is the last question. Oh, we have a microphone right here.
Oh, okay. My question is, I think one of the greatest problems today is use of marijuana. not only young people doing this before they go to school, before they go to bed all the time, but also for every one of us walking on the streets of New York, ingesting these vile smells. Now, secondhand smoke was a very big issue in trying to ban cigarettes. Is there going to be an investigation about what the effects of our ingesting these fumes will be to all of us who are not smoking marijuana?
Okay. And so, all right, so those are our four. If we can deal with these kind of quickly, you know, I pride myself on making sure that like my panels get in on time. And so this is like the pilot. It's like, no, I land safely most of the time, I promise you. So if we can get the collective care question and the about the extent to which the United States is atypical, and then we'll grapple with the last two.
Shall I deal with the question of that you raised about whether the US is atypical? So in almost every epidemic and pandemic, there will be the deniers and there will be those who go counter to what the public health advice is. I mean, I dealt with it firsthand in HIV when my president was an AIDS denier. So I had to deal with it up front because you have to tackle the issue. So it's not new to COVID. And what was different about COVID, though, is that unlike the past pandemics, in COVID, social media was much more widespread and became quite a dominant force in the way in which information was presented. So we never had, nobody just repeated and shared with thousands of people that HIV doesn't cause AIDS because the president said it, because it wasn't social media. So we had to deal with that. But across the board, what we did see in country after country, and this we did as part of the Lancet Commission on COVID-19, is that almost every country had to deal with the anti-vaxxers, had to deal with the deniers, had to deal with, oh, it's just flu, or that I don't want to wear a mask. There was no country that was spared. What was distinct was that there were certain countries where it became the official leader hunting this. And the classic were the three big countries, US, the UK, and Brazil. In all three countries, the presidents chose a different path from the one of science and the one of public health. And that's where we saw it worst. But it was present across the board. Even in New Zealand, there was a movement that was anti the quarantines that they imposed.
I wonder if you could grapple with the question about collective care while we're at it.
Yeah, I'm not sure I have much to add beyond the points we've already made about the need to move the narrative to one of the collective good. But just to add one point perhaps is that if you look at the narrative today on smoking, it has fundamentally shifted from anything that was present even 10 years ago, in that it's now the narrative has fundamentally accepted that it's in the general public's good to make people stand out in the cold and smoke and not have anything to do with any of us. And that's what, and we accept that. And it's become the dominant narrative. We haven't been able to shift it in that systematic way for many other things. And slowly we're on that path for climate change. So the skeptics and the deniers of climate change are now in the minority. But if you go back even 3 years, they were actually a dominant force, the climate deniers. But it was just the sheer flooding and the terrible summers that convinced people that it became part of this now, bottom-up kind of approach, that people are buying this narrative that climate change is here, it's bad for you, we have to do something about it.
Do you have, Harry?
No, I think I can take on two, I think. Regarding the epidemiological piece of it, I think that educating epidemiology, even the most basic way, and for that matter, public health issues in any way that can be humanized and taught to young people is incredible, because it would make it part of the fabric. kind of as we, as young people become part of the society, part of the world. So I think that would be incredible. And as for secondhand smoke, whether it's tobacco or marijuana, certainly an incredibly important public health issue. We know that it has profound impact from tobacco. It would be really good to understand what the impacts are from marijuana. So I think that was two.
Yeah.
Mhm.
So, all right, we have 3 minutes over, but I want to thank you all for coming and for sticking with us, and thanks Dean Freed for inviting us here today. Thank you.